So the last group of drugs that really are immunosuppressants are a group of monoclonal antibodies that have been developed to combat really aggressive exacerbations of asthma. And these drugs have kind of unique mechanisms that we have not talked about from the pharmacology perspective. And so these are monoclonal antibodies that are targeting specific human receptors and proteins and antibodies that really drive asthma pathogenesis. So the first drug that we're going to talk about is omalizumab. Okay, and this is a recombinant form of a humanized immunoglobulin type 1 molecule. Okay, that's an antibody to the human IgE antibody. So what this molecule does is that it's an antibody against an antibody. So it's an IgE antibody against, it's an IgG antibody against the human IgE antibody. And the human IgE antibody really plays a central role in pathogenesis of asthma. Okay, and so it binds to the specific epitope of the Fc region. I'm not sure if you guys have gone over antibody form and function, but I have a diagram that's going to show this much more clearly. This drug is injected, and what it does is it binds to circulating IgE in the patient, forms complexes with them, and then pulls them out of the circulation. It deactivates them. Okay, but by doing so, and this is clinically important, it doesn't actually activate the complement cascade. Okay, and so what you have to do is you have to look at the total serum IgE levels in the patient before treatment, and then you have to monitor how much IgE you're suppressing. Okay, this is extremely costly. Okay, and in some cases it might actually be cancer promoting. We'll spend a lot of time on immunosuppression and the mechanisms of how these drugs work in order to understand how this could possibly be even a remote side effect. But just, at this point, just take it for granted that I'm telling you this is possible. And this is an adjuvant therapy for patients who are older than 12 years of age. Okay, and so because of the cancer promoting ability, which is not extremely clear in the literature, but that risk is, it exists for sure. You want to avoid using this drug in patients that have a history of specific cancers within their family. So BRCA patients, in terms of breast cancer, would be a good example. All right. So how does this work? So here's omalizumab. Remember, this is a immunoglobulin antibody that looks like human IgG, but binds to human IgE. E is an Ed. Okay, so what it does is it binds to these circulating IgE molecules and it pulls them out of solution and basically removes them from the pathogenesis of asthma. Okay, and these IgE antibodies have several roles in terms of how they progress asthma. So there's an interaction here with plasma cells, of course, in terms of how they're being produced. There are high affinity receptors on the mast cell or on basophils that bind to IgE, as well as dendritic cells. And so all of this contributes to this allergic response, this allergic inflammation that really exacerbates asthma symptoms. Okay, and so omalizumab will pull circulating IgE out of the circulation and reduce its effect to basically stimulate the asthma progression. And so this is kind of the first drug that was kind of developed. There are other drugs that are coming through the pipeline. IL-5 is interleukin-5 is another important chemokine in the pathogenesis of asthma. And you'll see these drugs coming through. They're in various clinical trials right now for asthma. Mepolizumab and reslizumab inhibit the ligand interleukin-5. Benralizumab inhibits the interleukin-5 receptor. Okay, and so all these drugs work similarly in terms of the mechanism of action. The target is different, but the mechanism of action is the same. And we'll talk about this in much more detail as we go through the curriculum. But this is kind of your really your last phase in terms of asthma management. So as we talk about asthma management, I've provided these slides, and I think these are kind of good summary slides. And so what are the stages of asthma? And so this is kind of what the progression of the disease looks like, and I think these are helpful. So if a patient walks into the clinic with a new diagnosis of asthma, what are they given? Well, that diagnosis is what? Mild intermittent asthma. They're given a short-acting beta-2 agonist, like albuterol, as required. And then if symptoms improve, fine, we keep them on this and we monitor them. If symptoms don't improve, if the disease progresses, and this movement, I hope you can see my cursor, this movement this way is progression of disease, we'll add on inhalation steroids, okay? And so here we're looking at the use of a regular preventer therapy to basically control mild intermittent asthma that's being progressed, okay? And so as the progression continues, and some patients do progress, some patients don't, of course, we can think about adding a long-acting beta agonist like salmeterol or formoterol and look at responses, okay? And usually somewhere between step 3 and 4, in terms of our control of the exacerbations, we're looking at adding those immune modifying or those immune altering type drugs. So the leukotriene receptor antagonists, theophylline, the 5-lipoxygenase inhibitors. This is where you start to see those types of drugs being implemented for, control of asthma. Okay. And then, kind of in the more exacerbated, we're becoming a little bit more aggressive. We're looking at daily steroid tablets at really, really low doses. We're looking at increasing the dose of the inhaled steroids, and we're looking at kind of more aggressive types of therapy on top of our long-acting beta agonist and our anticholinergic type drugs. And so, maybe in this particular patient, assuming that all else is healthy, you would start to look at adding some of those monoclonal antibodies like omalizumab as the disease progressed. And so this kind of is a nice kind of example of how asthma gets exacerbated and when these therapeutic regimens become incorporated. Likewise, here's something that you would be that you would most likely find in one of those patient education brochures. Of all places, this is from Pinterest, but I like this because it basically looks at all the different drugs for asthma as their ability to be relievers of asthmatic symptoms, their ability to control the disease, drugs that are used in combination with each other. And so this is usually the short-acting or the long-acting beta agonist with the inhaled corticosteroid, and then the preventers. And so this is just another way of categorizing some of these drugs. All right, and so through some of those exercises, we'll go through some of these concepts in much more detail in some of the in-class sessions.